Welcome to the first in our iSense Q&A series. I am Erin Manning, the Communications Manager for the UCL-led iSense project, which is an EPSRC-funded interdisciplinary research collaboration focused on developing tools and technologies to track, test, and treat infectious diseases. We've started this monthly Q&A series to hear and learn from experts across academia, industry, government and policy, and healthcare on topics related to infectious disease, outbreak, preparedness, and response. Today, in the first episode of our Q&A series, we will explore the topic data sharing and privacy during a pandemic. I would like to welcome our guest speakers. We have the absolute pleasure of speaking to Richard Welpton from the Health Foundation, Boris Voitin from GSMA, and Jess Morley from the Data Lab at the University of Oxford. I'm so grateful to all of you for joining our Q&A series today. I'm going to give you the honours to introduce yourself. Richard, would you like to start?
Hi there. So I'm Richard Welpton. I'm a Senior Data Manager at the Health Foundation, working in our data analytics team. My role is really around acquiring sources of patient data for our analysts to make use of, provide some insights about what's happening with the health service and where we can make some improvements. And most recently, we've been using data to support our work, thinking about the COVID, the COVID crisis and what's happening in care homes and the health service. And prior to that, I did quite a similar role at Cancer Research UK, where I was acquiring data from Public Health England to look at cancer pathways. And I've also had positions at UK Data Service and Office for National Statistics.
Thanks so much, Richard. Welcome. Thanks for joining us. Jess, would you like to go next?
Sure. Hi, everyone. Thanks for having me. I'm Jess. I'm Head of Policy and Engagement at University of Oxford's Data Lab, which is headed up by Dr. Ben Goldacre. And we have most recently been working on our platform of work called Open Safely, which is England's largest secure electronic health records platform for analysis of the COVID crisis. And hopefully we can talk a bit about how the technical structure of that platform enables us to do large-scale analytics at scale whilst also maintaining privacy and transparency.
Brilliant. I'm sure we will touch on that, Jess. Thank you so much. And Boris, would you like to introduce yourself?
Hi, so my name is Boris Voitin. I'm the Director of Privacy at GSMA, and a lot of you probably aren't familiar with GSMA. It's essentially the trade association for all the mobile network operators around the world, so Vodafone, Orange, folks like that. There's almost 800 of them around the world. And so my role is really to look at any kind of data or data privacy issues from a policy point of view and advocacy point of view in the industry. So I spend a lot of my time talking to governments, trying to shape the sort of future regulatory landscape in a way that makes sense for everyone, and talking about data protection laws. There are a lot of countries that are still legislating data protection laws or implementing data protection authorities. So that kind of thing. And then when it comes to sort of COVID, we are very engaged on all kinds of initiatives around using mobile network data for social good or for social impact. And COVID is of course the one that has grabbed all the headlines and is in the spotlight, but it's something we've been doing for a while. And of course privacy comes into that. But to stress, it is our members that have the data, so the mobile network operators that have that data, and I'm looking at it from a sort of industry-wide point of view. Thanks.
Brilliant. Thanks so much. Thank you to all of you for those introductions. It's so great to have a wealth of different expertise on the panel. So I'm going to start with a very overarching question before we jump into some of the more detailed questions and get into the questions that are asked in the chat. and that is, how can you see data helping in a pandemic? Jess, maybe we can start with you and you can talk about it in the context of your particular work.
Sure. So the way that we have mostly been using data with regards to Open Safely is identifying specific groups who are more at risk for specific reasons of COVID in order to help with the policies and the responses that the government has been putting out. So, for example, our first big sort of analysis that we did as a result of Open Safely, which was in the first 5 weeks of us setting it up, was factors associated with COVID death in hospital. And because we have access to around 40% of the population's electronic health records, the reason we have access to that much scale is because the data doesn't move. The data stays inside the electronic health records platform providers where it already stays. And we work on behalf of NHS England, and we send the analysis code to the data rather than bring the data to us. And what this enabled us to do, because we had so much data of so many groups of people, is work out who within that is at greatest risk of having a negative outcome from COVID once they go into hospital. And that was really only possible by the fact that we have this large-scale trusted research environment and are therefore able to dig down into those specific niche groups. And so I guess that's one of the main differences between pandemic response and between may normally have the way in which you might use data in health, is that it's much more focused at identifying group level risks rather than necessarily looking at individual person's healthcare. And so that's how we've been using it. And I know many other excellent groups have taken a similar approach.
Great, thank you very much. Richard, would you like to answer that question? How can data help in a pandemic?
Sure. So obviously in many ways, and I think for my organisation, we've done a bit of work that touches sort of the tip of the iceberg, really, as I think most organisations are in the same place. I think for us, one of the things we focus on is what's been happening in care homes. And because we have a partnership with NHS England, where we access data which can be linked to care home residents, we've been able to look at care home residents who have been admitted to hospital and then see patterns of discharge back into care homes during this crisis. And there has been some work recently published on that. So yeah, I think we've done a bit of by linking data together, so looking at people's hospital records combined with their care home records, we've been able to see what's actually happening with care homes, which has been really important, and that's been an important part of that. We did have other plans as well. So, for example, we were very interested to see what was happening with capacities in intensive care units. I have to say we didn't undertake that analysis. We did apply to access data through the COVID data sharing service that was established by NHSX. But actually, when we were going through that process of applying for the data, we found out that Public Health England were doing that analysis anyway, and so for that reason we weren't able to access the data. So we sort of rely on Public Health England publishing that. But that was something we were really interested in looking at, just to sort of see how ICUs were coping during the initial months. And that kind of sums up our short-term responsive work to the pandemic. All of our other programs of work are now being adjusted to take account of the long-term effects of COVID. So we've already got a program of work around inequalities in health, and that's going to be adjusted to look at pandemic, what effects that's having on access to treatment. And similarly for our work on comorbidities and high need users, so people with multiple conditions, and how they're going to be treated in this sort of COVID world.
Yeah, That's really interesting and important work. Thank you very much for sharing. I'm just going to jump over to Boris to see if you have anything you'd like to add to that question as well. How can data help in a pandemic, particularly around what you're doing within GSMA?
Yeah, sure. So in order to answer that question, I think it really helps to make a distinction between three different types of things, or types of data. There's the mobile network operator data from the networks itself, and then there is what we call over-the-top data. So this is websites, applications, and that kind of thing. That is all activity that's happening on top of the network, if you like. And then there's data from handsets or in the handsets themselves, which is a different kettle of fish. So, of course, our members are the mobile network operators. And when you think about mobile network data, you think, well, there's the sort of customer data in itself when you register for a phone, or you get a phone, you have an account, and whatever. But then there's all the network data, which is the calls, the SMSs, and the events, the cell tower data that's associated with those events. And from that, you can also have geolocation data, not very precise, but at least something. And that's potentially really, really useful for all kinds of things, particularly when you bear in mind that mobile networks really cover most people in the geography where there's good mobile phone penetration, like in the UK. And not only that, really most countries have 2, 3, or 4 mobile network operators. So you only really need one of the largest ones to be able to get a good proxy set of data for the whole population. And from that, you can get some really useful insights. And so I stress this is not identifiable information. This is data that has been de-identified and then analyzed and produced in a anonymized, aggregated way. So, the sort of end customer, say the government or PHE or whoever, just see a dashboard or something. And the kinds of use that we've seen around the world for that are understanding how the disease will spread, so that you can plan resources. How many doctors and nurses are you going to need in a location? Do you need to build a new hospital? How are confinement policies going to work? What sort of impact are you going to expect of that on the disease, but also socioeconomic impact of those kind of policies? How can you tailor them more effectively? You know, is it a certain age group or certain geography? Can you be more specific about where you have the confinement? And when is the best time to implement those kind of confinement policies? And also for the future, for early warning systems, when you might expect a new outbreak or a different disease to come along. So you can see that there's really actionable intelligence for policy making in that network data. Then on the OTT side, the over-the-top side, that's where all the talk that we had about contact tracing in the media, there was a lot of hype about that, if you remember a few weeks or months ago. That was really more about the apps created by universities or governments, and it's data collected from the apps, not from the networks. So a different kind of ball game there, but that is really to understand people's contacts. And although it started on location data, really the focus swung around to proximity. And that brings me on to the handset data, and I'll stop talking in a sec, but the handsets are really part of that mobile ecosystem. And in order to understand proximity well, you have to rely on the Bluetooth signals. But of course, every smartphone has a different kind of antenna in it. So the strength of that signal might give you a different kind of piece of data for how close you think someone is for how long. So we did a lot of testing members did a lot of testing to try and come up with a sort of standardized figure that you can put into those formula when talking about proximity. So there are like 3 different kinds of thing going on there, and we can dive into any of these.
Wonderful, thanks for sharing. Within iSense, we did look at some mobile data for COVID as well. We've been looking at mobility data and how people have been moving around the UK throughout the pandemic, and that's been really interesting to look at. Staying on the topic of telecoms and mobile data, reflecting on the last few months in your experience, are there maybe things that need to change within telecoms companies to ensure data sharing during a crisis can be done in a faster, privacy preserving manner, or have those kind of legislations and rules and regulations been implemented already, and there hasn't really been any issues that you've seen during COVID-19?
Yeah, I mean, that's a big question. So I think on a sort of operator by operator basis, many of our operators have been doing data analytics with mobile network data for a long time. They know how to handle it. They know how to build in privacy protections when they de-identify it and they aggregate it and so on. And actually, some of them were very quick off the mark, offering to help governments. In Norway, they did, long before any lockdowns were brought in, they were already working with the government anyway to try and figure out good solutions. So sort of on a case-by-case basis, they can be very quick off the mark. And also, I think we should say that when this has been looked at from a privacy point of view, we've had from the most senior authorities in Europe, we've had statements from them and guidance from them saying, look, in principle, data privacy rules are okay for this. You can do this, particularly if we're talking about that anonymous kind of data, then that should be okay. Of course, you need to still, from an operational point of view, you need to have those privacy safeguards in place to make sure it is anonymous. And that when the data is received by the government or the researcher, it remains non-identifiable. So that's sort of on the plus side. I think there is room for improvement if we look to the future in terms of how we all collaborate. And that's not just the mobile operators. I mean, the mobile operators can sort of know what they're doing. Sure, they can get better at collaborating and think about platforms or whatever, or new technologies to incorporate. But there's a lot of work to do on the government demand side. Maybe not so much in the UK, but if you think and sort of more globally about governments around the world, a lot of them lack the capacity or the skills to even know what to ask for in the first place, never mind to do something sensible with it. So there's a lot of capacity building we need to do as a community, and to work with the WHO, with all the international institutions, so that we can be more shovel ready when the next thing happens. And there's a lot of attention on that. So I think we're all agreed that it wasn't quick enough this time, but we keep learning.
Yeah, that's really interesting, and good to hear that it's a collaborative approach, and it requires lots of different people from different sectors to come together and kind of consider those changes that need to happen for the next global crisis or pandemic. Richard, I had a question for you. Having access to vital data can make a huge difference for researchers, especially during a pandemic. But sometimes access and use of that data can be a long and limiting process. How would you suggest the process can be made quicker, particularly in the context of a pandemic?
I mean, this has been an issue that has plagued researchers for quite a number of years. And I'd count myself as somebody that liaises between researchers and data suppliers as being one of those people that have been, felt acutely that long and limiting process. I mean, I think in some respects, what the pandemic has enabled through legislation, we have this control of patient information regulations, which have been relaxed in the pandemic in order to allow national agencies to share data with each other. And I have heard anecdotally of some really nice examples where Public Health England and NHS Digital have been able to share data about patients, and that resulted, for example, in the letter going out to all the patients that needed a shield relatively urgently. And likewise for agencies undertaking research by perhaps contracting researchers, has improved the speed by which research can be undertaken looking at pandemic. I think kind of outside of the scope of a pandemic, there's still a big problem. And I think I really welcome the efforts that HDR UK have been making, setting up the, I think it's the Innovation Gateway, which is now meant to be a sort of one-stop shop for researchers who are trying to access data, health data. It should direct them to the appropriate agency and guide them through the process. And that's going to be a big help. I think whether you're accessing health data to do work into a pandemic or otherwise, I think there are sort of a few key lessons. I think one is ensuring that data suppliers and academic researchers talk the same language is really important. And I know, speaking to data suppliers in the past, they can be bamboozled sometimes by some of the way that academics explain how they're going to be using data in their applications, and that means that they can't assess whether use of the data is safe, is legal. So they're unable to make a recommendation to provide access to the data, and it's often language, it's kind of ironing out those kind of things. Really makes a difference. But likewise, I think data suppliers, need to understand, what it is researchers are trying to do. And I think another issue as well, which has sort of been around for a little while, is predicting what the outcomes of the research will be. There seems to be more of an emphasis being placed on researchers by data suppliers to say exactly what the outcomes of their research will be. And the thing with research, of course, is we know you're never quite sure what the outcome is going to be until you actually do the work. So, and if we knew that, we probably wouldn't need to do it. So that's a bit of an issue too. And they are, I know people like NHS Digital have taken these comments on board. I think one of there have been some positive signs though over this pandemic, and I know NHS Digital and iGuard, which is the independent panel that assesses applications to NHS Digital, have tried to make efforts to speed through data applications. So iGuard now meets weekly instead of fortnightly, and prioritise any applications which are to do with COVID. And that's been the same with the GP data available from CPRD. So anything with COVID has been prioritised over this little while, and that's been really good to see. So if there was one thing that I think could be made easier, I think it's brokering that language between researchers and data suppliers so that they're talking about the same objectives, and that's ultimately what's going to make the data suppliers' decision easier in terms of making data available.
Yeah, thanks for sharing that. It is good to hear that there have been some positive data sharing experiences though that you've seen throughout the pandemic. Jess, a question for you. So I know that your work focuses particularly on the use of AI in healthcare, and while there are obvious benefits for the use of AI and other digital technologies, there are also broad ethical risks involved too. How do you recommend best addressing ethical concerns related to data sharing and privacy so that there doesn't have to be trade-offs between transparency, privacy, and scale, particularly in the context of a fast-evolving pandemic?
Yep, sure. So I guess the first thing to make clear is that Open Safely, which is the example that I was talking about before, does not use AI. We use very much old school epidemiological research techniques. The stuff my research to do with AI and ethics is more to do with my other Oxford hat on, but the two are not far apart. So AI, and in fact most data analytics projects, requires access to huge volumes of data in order to train, but also in order to have a higher statistical enough power, so to be able to be confident enough in your results. And that's often a problem because of some of the problems that we've just been discussing. Often the way that data is moved around the system is quite high risk because it is done by large data extracts, and that's sent to different groups of people, which can have quite problematic risks in terms of disclosiveness and in terms of privacy issues. Even if that data is sent in a de-identified form, there are a number of ways in which it can be re-identified. What we have been trying to do with Open Safely is demonstrate the fact that by using a specific technical structure, you can minimize those risks. So the data doesn't get moved. The large-scale disclosive data does not get moved. The electronic health record bit stays where it is, stays where it's stored for business as usual purposes, which means we can have access to a much larger volume of data. We don't need to move it. The second thing is the way that it's designed means that researchers never need to access the raw unidentifiable data. Instead, people write a study definition. That definition is translated by software that goes to the data, and it brings you an extract. That's the dummy data. It's not real data. It's dummy data in order to test that your model works, and then it runs against the platform, and all anybody ever sees is the results and the output. There's then an extra level of protection where somebody reviews those outputs in order to make sure that there are no what we call small numbers, so where we think there are too few results, then that might be a risk. The advantage of that as well is that every single study is recorded and it's public. It's in GitHub. Other people can use it, so other people can reuse it, but it also means that there's a log for every single question that has been asked against the platform. So one of the things you often see with people who are concerned about transparency is I don't actually know who's had access to my electronic health record for other purposes, whereas in the use of our platform, you can see whoever has asked a question for what reason, and you can follow the trail all the way through. So what that means is you are minimizing the risks of privacy infringement because we have, as far as possible, reduced the risk of re-identification. Nobody is accessing the raw identifiable data. We've improved transparency because we have a log of every single person who's using it. And we have, because it's so much more efficient and so much more secure, that enables us to have a far greater level of scale. And so as much as we are not using the platform for Open Safely for sort of AI purposes, the platform itself, so not the data set, which we're currently using for purely on behalf of NHS England for COVID-related reasons, the platform, the software platform, could be used to enable AI researchers against other databases whilst minimizing the privacy and security risks. That doesn't minimize some of the other ethical concerns like accuracy and validation and how you might impact on somebody's autonomy and any of these other things, but in terms of data access and data privacy, that massively helps, and it massively helps prove rather than just rely on a vague concept of trust that what we are doing is private and secure, whilst also maintaining a degree of transparency.
Thanks for sharing. That sounds like an amazing platform. How would you say that we can make sure we're using data for good?
well, a number of ways. I mean, I think the very good thing about COVID, if we can say that, is that it has highlighted the ways in which health data can be used for massively good purposes. I think sometimes we often stand, and often ethical researchers like me are a little bit killjoy because we can be a bit like, oh, well, you know, you shouldn't use this and you have to think about all of these things. But there's an ethical cost of opportunity cost too. Not using data can be also ethically problematic if we think it can save people's lives or provide very valuable insights. The way that you can make sure that data is used for good purposes is by building very robust governance structures in place. So making sure you have a process in place that's efficient, so not this slow process which many people have been describing already, of reviewing what you're doing the data for. You then have this log of what that data was used for. You have a thing that's person reviewing the output. And if you involve multi-stakeholder engagement in the design of that governance process, so making sure you're taking into account what societal expectations are, what do we think is a good use of data, what do we think is a red line use of data for different people, and making sure those voices are heard and built into that governance process, you can enable its use, because we have quote unquote solved some of the security issues, and you're left with the regulatory and the cultural aspects. And by inclusive engagement processes in building and designing the governance, you can minimize that. That doesn't mean it's ever easy, but you can at least enable it.
But very important.
I just jump in just to completely agree with what Jess just said. There's always this sort of perceived tension between privacy, human rights on the one hand, and what you can do with data, whether it's in a commercial setting or sustainable development goals or COVID response. And really, it's the wrong sort of lens to look at it through. It's really, instead of seeing privacy and human rights as a barrier or some sort of compliance headache, we've always thought, and I personally, as a sort of data privacy person, have always thought of privacy as part of the solution to unlock those the benefits that you can get from data. You just have to incorporate the right kind of safeguards, and a lot of it's around risk identification, mitigation, and avoidance, and so on. But if you can do all those things and do it transparently, and in the case of COVID, do it in a way that's time-bound and transparent, so that people can have that trust that what you're doing is not setting up some sort of surveillance state. You are doing something that is designed to help for this specific purpose in a time-bound way, then people will be more than willing to contribute to that. And I think surveys show that time and again. People want to help, but they have to trust in their systems. So and that's why we had our privacy guidelines for COVID, which were quite well received, talking about not just what mobile operators do to de-identify and anonymize the data, but also the reassurance that we need from governments in order to be able to give them access, or researchers, or whoever's doing it with the government or for the government. We need that reassurance back the other way to say we're only going to use it for this purpose. This is what the purpose is, and here's who has access to the data. And yes, we won't re-identify the data, and those kind of things. So at a sort of organizational and policy level, as well as at a technical level, there are things you can do to just unlock the good that's in the data.
Yeah, I think the pandemic has definitely shown us the power of communication and engagement with the public, and in every stage of the pandemic. There's a question from Rachel McKendry here, who's the director of iSense. She says, "Thanks so much for a great panel debate. Looking ahead to the next stages of the pandemic, what do you see as the biggest data challenge?" Maybe Richard, we can start with you.
I mean, I guess there are a number of challenges that it's raised. I guess one of the things we're interested in is looking at ethnicity. I mean, that was one of the things that was highlighted a lot over pandemic, and the challenge is, how can we collect and make available good data on patients' ethnicity? It's always been a problem in the health service. There just simply aren't good records about people's ethnicity, and it's really crucial that we start collecting these data and so we can look at some of the inequalities. And actually, I was really heartened to see some of the work that the Office for National Statistics are doing in this area. They are able to now to understand, obtain health records and combine with some of their detailed survey data to get better measures of ethnicity and occupations as well. That's been critical. So I'd say ethnicity is one challenge. The other actually is environmental sustainability, and there have been reports out about the effect of COVID in areas of poor air quality. So that's another area that we're keen to begin looking at. That's just two of what I think will be many. So I'll hand over to my fellow participants.
Thanks very much for sharing. Jess, would you like to add to that?
I mean, I think largely the same. The biggest challenges are where we don't have the data. So that's ethnicity is a big one, but there are many other examples. There's also the fact that in some ways the next wave of the challenge of the pandemic is dealing with the fallout. So what has happened both in terms of people who have got seemingly long-term effects of having had COVID, but also the long-term impacts on the healthcare service. You know, a lot of things were paused or redistributed, or in order to deal with the first peak of the crisis. That's going to have massive knock-on effects on different reasons, whether that be people who have been receiving cancer treatment or the way that we've redesigned primary care. And getting hold of the data, managing, monitoring that in a sort of almost real live way over the longer term, when some of the enablers from a legal perspective potentially gone, is going to be very challenging. Is monitoring the sort of longer term impacts, I think, for sure.
Yeah, thanks for sharing. Boris, do you have anything to add to that?
Yeah, so just looking at it slightly differently, maybe from a sort of policy legal point of view, there have always been some sort of challenges on this kind of activity, grits in the system, if you like, that make people stop and think, maybe we shouldn't do this, or you hesitate because there's a sort of question mark over whether you should or you shouldn't, or you can or you can't. And I think COVID has helped in a positive way to sort of shine a light on that and say, and force us all collectively to think, well, is this a problem or is it not a problem? So one of those things, for example, is the use of aggregated data. Is that anonymous or not anonymous? Privacy sort of fundamentalists will point to they also want it to be absolutely 100% never re-identifiable, but really there's more of a reasonability test as to whether it can be re-identified or not. And I think that's the route that European data protection regulators have gone down. And I think that, if we carry that forward into the future, I think that will give a lot more certainty for these types of activities in the future, to say, look, if you're doing all the things you possibly can to make it anonymous, by aggregating it, having the right thresholds and understanding your data, then this kind of activity is good. Another grit in the system type thing is that, well, you get internet companies like Google and Facebook are able to do all kinds of things with their data, provided they comply with general data protection law, but yet telecom companies have sort of additional legal barriers to get through, and those rules are up for discussion in Europe and have been for the last few years. And we also need to make sure that we're being sensible about what are the rules that apply to all of this kind of data, so that it's consistent. Taking data across borders and so on. And then the other biggest challenges I mentioned before, the sort of skills and capacity of governments around the world, not in the UK, but in other places in the world.
Yeah, they're all very interesting points. I guess following on from that, I have a question. I guess there's a lot of concern about how data that has been made available for the pandemic might be used beyond the pandemic. How can we mitigate this and make sure that's not the case? Maybe Boris, you could continue from what you were saying.
That ties in with the challenges as well, because one of the things that I think we keep bumping up against is it's fine to, you might be happy to give the data for a specific purpose and specific conditions, but actually, if and this was very much in the COVID situation, that was part of the debate. You had people everywhere having a sort of knee-jerk reaction saying, look, who cares about the human rights and privacy aspects? Let's just have the data so we can solve this COVID thing and not lock down the economy. But you have to be quite brave at one point to say, well, look, hang on a minute, let's not accidentally set up something that will then just be an indefinite tool available to a government to be able to monitor the movements of its citizens. We don't want to create that kind of environment. So how you kind of make that limited in time and call back or call off the arrangements, and how you hold a government to account in that situation, or the research institution for doing stuff with the data, how do you sort of unwind those arrangements, or how are you transparent about those? I think those are definitely key things we need to think about.
Great, thank you. Jess or Richard, do you have anything to add to that?
I mean, I largely agree with everything that's Boris has just said. I would say the one advantage of using trusted research environments is that you can then turn off the access, as opposed to this idea if you sent the data to someone, you then don't know if they continue to use it beyond the endpoint. So that's the sort of some semi-technical fix to some of that, but it continues to be a big concern. Yeah.
Richard?
I mean, I think we've just coincidentally we've been doing an exercise recently where we've been working with patients to explain to them how we keep patient data safe, and actually engage them to write some of our documentation that's about to be published on our website, our public-facing documentation on our website. So getting patients to write that for us so that other patients would be able to understand that. And that's been a really interesting exercise. And I'm just sort of thinking about some of the questions they were asking me, and it was around, what processes do you have in place to stop researchers using data for, different projects which haven't actually been approved, and that really kind of forced me to think about, well, how do I explain those data governance arrangements to these people who don't have my kind of background. I think that's been really positive. So yeah, sort of, I think their key concerns were, well, we definitely want the data to be used, and that, reflecting back on what Boris was talking about earlier. Surveys show that people are generally happy for data to be used for public good. But yeah, they want to make sure the safeguards are in place. How do we deal with hacking? That was a question that kept coming up. And of course, we've got robust procedures to stop that happening and to deal with hacking if it ever occurred. So it's just being transparent about it and reassuring people that, this trusted research environment solution, which Jess alludes to, they are secure and they are safe. And just making sure people can understand that. I think that's going to be really important.
Yeah, all very important points. So we've actually come to the end. That's been really quick and gone really fast. And I have so many questions I want to ask, but I think just to finish, if each of you could give one sentence about if there was one thing that you would like people to learn from what's happened over COVID-19 in terms of data sharing and privacy, or one nice thing that's happened, what would it be? Maybe Jess, you can go first.
I guess my main thing is that use of data is good. It is a public good. It isn't. You don't have to make a trade-off between privacy, transparency, and security, and you can use it, and it is possible to design in a way in order to enable data use for the public good, and that has happened on a far greater scale in COVID than it has done previously.
Wonderful, that's great to hear. Richard, would you like to go?
And I think one of the things that the COVID pandemic has done is put data at the forefront of people's minds a lot more than it was before. And so we've got to deal with what safeguards we have in place, balance and get a proportionate balance between risk and using data for public health, and being transparent about the safeguards that we have in place.
Thank you. And Boris?
Yeah, I'd largely echo what the other two have just said. I really welcome this big spotlight that has been shone on the issue of making data available, that it is possible, provided you do it responsibly and you're really thinking through the ethical and human rights and privacy issues. I said, as we look to the future, there's going to be a lot more of this kind of conversation, not least because there's demand for it, but also because the European Union are looking at this from a policy and legal point of view about opening up data and data sharing, business to government data sharing. And I just sort of sow the seed that it's great in principle, and everyone wants that to be able to happen. But of course, there is also a sort of sustainability argument from the point of view of an organisation that has invested in kind of infrastructure and doing what it's doing, and then to sort of just be handing over the data for free all the time, then creates a situation. And I think it's just, if you take a step back from all our sort of entrenched positions of where we all, our interest groups, is what is a fair system to be able to open up the data that should be opened up, but also allow it to be commercially exploited in a safe way in
Yeah. Thank you to all three of you for joining us today. Unfortunately, that's all we have time for. But it's been a pleasure to speak to all of you, and thank you for taking the time to join us.
Thank you.
Thanks.
Thanks so much.
Thank you.
Thank you for joining the first in our iSense Q&A series. If you liked what you heard, our next episode will be on diagnostic testing, lessons from the pandemic, when we'll speak to Professor Rosanna Peeling and Dr. Tim Huggett. Hope to see you there.